Welcome to Pathology Central Key Concepts. The topic of this video is pancreatitis. In this video, I will begin by reviewing the role of the exocrine pancreas, followed by a discussion of the various etiologies and morphologic findings of acute pancreatitis, and finishing up with a discussion of chronic pancreatitis. So remember, what does the exocrine pancreas do? It's very critical for digestion, and in fact it produces digestive enzymes that are stored as inactive proenzymes in zymogen granules. These include enzymes like trypsinogen and chymotrypsinogen and carboxypeptidase, etc. And when we get the appropriate stimulus, trypsinogen will be released into the duodenum, where it will be cleaved by enteropeptidase to yield the active protease trypsin. Trypsin will then cleave and activate the other proenzymes, leading to proteolysis. And trypsin actually also cleaves itself so that it can inactivate itself as a negative feedback loop. There are also trypsin inhibitors such as PINK1, and this will become relevant a little bit later in this video. There are other enzymes necessary for digestion, such as lipase and amylase, that are made in the pancreas that do not require activation. So acute pancreatitis is a reversible inflammatory disorder that can range from just simple focal edema with a sprinkling of fat necrosis to widespread hemorrhagic necrosis and death in up to 5% of patients. Globally, it accounts for about 33 to 74 cases per 100,000 people, and in the Western world, about 5 to 35 cases per 100,000. The primary etiologies that you need to recall are gallstone impaction of the common bile duct, which accounts for 40 to 70% of cases, and excess alcohol intake that accounts for 25 to 35% of cases. Together, these account for more than 80% of cases of acute pancreatitis. So when we consider a gallstone impaction of the common bile duct, we know that we have a female preponderance. That is in contrast to what we see with excess alcohol intake, where we have a male preponderance. And then just to put this into some perspective, because gallstones are very common, only 3 to 7% of patients with gallstones will develop acute pancreatitis. With excess alcohol intake, we know that about 10% of patients with chronic alcohol use disorder will get acute pancreatitis. Now, in addition, there are some other mechanisms that you should be aware of. So we can get other obstruction of the pancreatic duct, which is not related to gallstones. This can be pancreatic cancer, biliary sludge, or parasites such as Ascaris lumbricoides. There are a variety of metabolic disorders that are associated with acute pancreatitis, such as hypertriglyceridemia, hypercalcemia, for example, due to hyperparathyroidism. In addition, there are a variety of medications, such as anticonvulsants, some cancer chemotherapies, and thiazide diuretics that can cause acute pancreatitis. And you should be aware as well that there are some infections, such as mumps and Coxsackie virus, that can lead to acute pancreatitis. And then finally, there are some genetic polymorphisms that can lead to acute pancreatitis. So you're all familiar with the cystic fibrosis transmembrane conductus regulator, or CFTR. There are many different alleles and polymorphisms in this particular gene. Some of it will manifest with full-blown cystic fibrosis, such as delta F508, but others which may simply manifest with pancreatic symptoms. We can also see polymorphisms in the gene that encodes trypsinogen, as well as SPINK1, which is a trypsin inhibitor. So these can be causes of some hereditary pancreatides. So the pathogenesis of acute pancreatitis is essentially that we get intra-acinar activation of pancreatic enzymes, leading to autodigestion of the pancreas. And there are 3 primary arms to this. We have pancreatic duct obstruction, primary acinar injury, and defective intracellular transport of proenzymes. And I'm going to go through each of these using a fantastic figure from Robbins and Kumar Basic Pathology. So here you can see the entire figure. I'm going to go through it piece by piece, beginning with the causes and then the mechanism of each, and then we'll finish up with what we see at the end. So let's first focus on our 3 causes. So we have duct obstruction, most frequently due to cholelithiasis, but also ampullary obstruction. Alcohol use, you will see, is a contributor to each of these, and I'll describe why that is later. We can get ductal concretions as well that can obstruct ducts. We can get acinar cell injury through a variety of mechanisms, which I'll discuss, as well as defective intracellular transport. So let's begin with duct obstruction. So in the pathogenesis of pancreatic duct obstruction, what happens is we get blocked ductal flow. And with that, we're going to get increased intraductal pressure and the accumulation of enzyme-rich interstitial fluid, because this blocked flow is going to ooze out into the surrounding parenchyma. Now, as we get this, we also will get the release of lipase, which is part of this enzyme-rich interstitial fluid. And this is going to contribute to fat necrosis and cell injury. And with this, we're going to begin a pro-inflammatory cascade with the elaboration of pro-inflammatory cytokines, and we're going to get interstitial edema. Now, this interstitial edema is going to cause further vascular compromise because as you have this additional pressure, it's going to shut down those small, flexible capillaries. This is going to lead to vascular insufficiency and further ischemic injury to our acinar cells. So let's take a look here at our figure, looking at our causes, and then again here, this interstitial edema caused by that obstruction. This is going to contribute to impaired blood flow, ischemia, and acinar cell injury. Now, the next arm we want to consider is primary acinar injury. And there are a variety of different causes. Most of them are fairly straightforward. So ischemia, viral infection, medications, direct trauma. I wanted to take a moment to talk about hypertriglyceridemia because to me, at least, it wasn't immediately obvious why this would cause primary acinar injury. So the thinking is that when you have abundant triglyceride-rich chylomicrons, it's going to increase the viscosity of the blood, slowing down flow, and perhaps this contributes to ischemic injury. In addition, when we have abundant triglycerides, these can be hydrolyzed to toxic free fatty acids in the pancreas, leading to cell injury. So here we have our primary cell injury, all of these pretty straightforward. And with this injury to the acinar cells, we're going to get the release of intracellular proenzymes as well as those lysosomal hydrolases, which can activate these enzymes. And we can get intracellular and extracellular activation, leading to acinar cell injury. Now, this brings us to the final arm, which is defective intracellular transport of proenzymes, and this is based on an animal model. So, as you know, proenzymes are usually kept separate from hydrolytic enzymes because otherwise they would be activated. And if we have some sort of defect in intracellular transport, we'll get the packaging of pancreatic proenzymes at the same place as hydrolytic enzymes, and so this can cause activation. We'll get proenzyme activation, lysosomal rupture, release of activated enzymes, and you guessed it, acinar cell injury. So here's what we can see here, and you'll see alcohol as a component here as well, intracellular activation of enzymes, and our acinar cell injury. So let's take a moment to talk about how does alcohol fit into all of this. So one of the things that alcohol ingestion will do is to increase pancreatic exocrine secretion. So we're going to get more fluid coming out. With the secretion of this protein-rich pancreatic fluid, we can get inspissated protein plugs. So we can get these concretions that will obstruct the small pancreatic ducts, leading to that increased intraductal pressure and interstitial fluid. Alcohol also causes contraction of the sphincter of Oddi, which will, again, prevent release of our pancreatic fluids from the pancreas, leading to increased intraductal pressure. And then alcohol has direct toxic effects, inducing oxidative stress in our acinar cells, causing membrane damage, and perhaps plays a role in the fusion of lysosomes and these zymogen granules. So let's put it all together with our causes and our mechanisms, all of which are leading to acinar cell injury. So let's take it to the final part of this figure. We have our acinar cell injury, and this is what is going to happen with all of these activated enzymes. So we're going to have the release of proteases within the pancreas that are going to cause additional proteolysis, this proteolytic cascade, and parenchymal injury. This injury is going to bring in acute inflammation. With acute inflammation, you get edema. Edema is going to cause pressure on blood vessels, further compromising blood flow, leading to ischemia, additional acinar cell injury. We're going to have areas of fat necrosis as lipase is released. This is going to cause inflammation. And then the release of elastase, which is activated from proelastase, is going to cause digestion and damage to vessel walls, leading to hemorrhage. And all of these together are going to lead to the findings we see in acute pancreatitis. And I wanted to take a moment to talk about trypsin because trypsin is really key to this entire process. Because in addition to simply activating our proenzymes, it also activates components of coagulation as well as complement, kallikrein, and fibrinolytic pathways. In addition, we can get inflammation and small vessel thrombosis, which is going to lead to acinar injury, and increased intrapancreatic enzyme digestion. So what will we see morphologically? Before we talk about our gross and microscopic findings, let's review the processes so we can anticipate what we will see. We're going to get microvascular leakage, which will lead to edema. We're going to have the release of lipase, which is going to lead to fat necrosis. We're going to have an acute inflammatory reaction, again leading to edema, as well as microscopically we'll see inflammatory infiltrate. And with the proteolysis of the parenchyma and blood vessels, we're going to see interstitial hemorrhage. And in fact, this is what we see. So grossly, we can see areas of chalky white fat necrosis, hemorrhage, and necrosis. And then microscopically, this edema, fat necrosis, hemorrhage, and parenchymal necrosis, as well as interstitial inflammation. So let's begin by looking at a fairly mild case of acute pancreatitis. You can make out here that the organ is not tremendously swollen. We have a few foci here of fat necrosis, this chalky white appearance because we get saponification. With the release of our free fatty acids, we're going to get calcium that's going to deposit here. And then you can appreciate here these areas of hemorrhage. So this is a typical finding in acute pancreatitis. Let's take a look at the histology here. This is an image showing some pancreatic tissue with acute inflammation. There's additional acute inflammation here and here with areas of necrosis. And then this large triangle here is of fat necrosis. Now you can compare this necrotic fat to viable fat here, which maintains its cell membranes. Here you can see thickening and deposition of calcium soaps where we get this pinkish thickened appearance. And then if we look at areas of significant acute pancreatitis, perhaps one of those hemorrhagic areas, you can see we have hemorrhage through here, destruction of the parenchyma. We have a residual islet remaining here, and look at this abundant acute inflammation with neutrophils. And then in a much more dramatic case, this is an autopsy specimen of acute hemorrhagic pancreatitis. This is the stomach that has been reflected up over the pancreas, and you can see that we don't have anything that looks even remotely like a healthy pancreas. It is this glistening, gelatinous mass with areas of hemorrhage and just a lot of edema fluid. So how do we make a diagnosis of acute pancreatitis? The most sensitive and specific test you should employ is serum lipase. It tends to be elevated for 8 to 14 days. Now, historically, serum amylase has been used, and you'll see this in some of the older physicians may still order this. Serum lipase is the indicated test. Serum amylase has a short half-life and returns to normal in 3 to 5 days. So if you are given a choice of one test to order, lipase is the one to go for. Now, both of these will be elevated about 4 to 12 hours after pain onset. Now, another laboratory test of value is to look at calcium levels because with extensive fat necrosis, we're going to get that precipitation of calcium ions due to saponification, and this can lead to hypocalcemia, which is a negative prognostic indicator. And then radiologically, we can see pancreatic swelling. So how do these patients present? So almost all of them will present with abdominal pain. Now, fortunately, about 80% of cases are mild and self-limiting because full-blown acute pancreatitis is a medical emergency. Now, these individuals are going to present with constant intense pain that's referred to the upper back, and they may have had previous events of acute pancreatitis. Now, your differential diagnosis is going to include perforated peptic ulcer, biliary colic, acute cholecystitis with rupture, and bowel infarction. And with the exception of biliary colic, all of these are medical emergencies. The easiest way that you can make this diagnosis is to do your serum lipase. Now, with the dramatic findings of acute pancreatitis, we can get disseminated intravascular coagulation and acute respiratory distress syndrome. This accounts for the high mortality that we can see when we get to full-blown acute pancreatitis. The increased microvascular permeability will lead to hypovolemia, which can lead to hypovolemic shock. And as we get breakdown of barriers between our gastrointestinal bacteria and the bloodstream, we can get endotoxemia and sepsis. And acute tubular injury to the kidney can lead to renal failure. So as I mentioned, the majority of cases are quite mild, about 80%. So you're going to provide supportive care, maintaining blood pressure, pain alleviation, etc. We also are going to provide pancreatic rest by making the patient NPO, which stands for nil per os, which means nothing by mouth. I wanted to share this image from Robbins and Kumar Pathologic Basis of Disease. It's a little bit simplistic, but we're going to compare this to what we see in chronic pancreatitis. So here we have our inciting causes that are going to cause activation of our digestive enzymes and inflammatory mediators, resulting in vascular injury and acinar cell injury. But this is a mild case. We're going to get resolution, and it will return to looking approximately like it did before the acute pancreatitis. This is different from what we will see in chronic pancreatitis. Before we move on to chronic pancreatitis, I want to talk about one of the potential sequelae of acute pancreatitis. So pancreatic pseudocysts can be seen typically following an acute pancreatitis, especially superimposed on a chronic alcohol-related pancreatitis. So as we'll discuss in a moment, excess alcohol use can contribute to chronic pancreatitis. And if you have an individual who has had chronic pancreatitis and then they have an episode of acute pancreatitis, perhaps exacerbated by excess alcohol intake or eating a large fatty meal, this can cause this acute pancreatitis that may lead to a pancreatic pseudocyst. And what happens is, with this extensive hemorrhagic fat necrosis, the body's going to try to wall that off using fibrosis and granulation tissue. And this will typically be a pseudocyst that will appear on the surface of the gland. It's usually solitary and resolves spontaneously, but because it's on the surface of the gland, it may involve and perforate adjacent structures, and it may become infected. We call it a pseudocyst because it does not have an epithelial lining. The lining is this fibrosis and granulation tissue. So let's take a look here. You can see here this is the pancreas, and this is that pancreatic pseudocyst. Now they're typically rather small, but they can get up to 10 to 20 centimeters. And you can see here it's glistening and filled with fluid. On microscopic examination, you can appreciate there's no epithelial lining. We simply see mixed inflammation, some granulation tissue, and reactive fibrosis. So this brings us now to chronic pancreatitis. So chronic pancreatitis is prolonged pancreatic inflammation that leads to irreversible destruction of the exocrine pancreas and fibrosis. And over time, with extensive chronic pancreatitis, we can even get loss of our endocrine function. It typically will follow repeated bouts of acute pancreatitis, most commonly associated with excess alcohol use, and it tends to affect males more than females. Now, even though we say that chronic excess alcohol use is the most common cause, up to 25% of cases have a genetic basis, again, taking us to our genes for trypsinogen, SPINK1, which is a trypsin inhibitor, and CFTR. And the pathogenesis of this is that we get this chronic pancreatic injury that's going to cause the release of inflammatory mediators that in chronic pancreatitis, as opposed to what we see in acute pancreatitis, are fibrogenic. So these are going to include transforming growth factor beta and platelet-derived growth factor, and these are going to cause the activation and proliferation of the stellate cells, which are the periacinar myofibroblasts in the pancreas. They are going to begin depositing collagen, leading to fibrosis. So morphologically, what we will see when we remove the organ is that it's going to be very firm and fibrotic, and it can have dilated ducts with calcified concretions. Microscopically, we're going to see parenchymal fibrosis and a decreased number and size of our acini all the way to acinar loss. There will be variable dilation of our pancreatic ducts, chronic inflammation, and over time, loss of our islets of Langerhans. So let's take a look at this example of chronic pancreatitis. You can see here this pancreatic duct, which is filled with this concretion of inspissated secretions. And then if you look surrounding it, there is no residual pancreatic parenchyma. All we see is fibrosis and some scattered inflammatory cells. Here's another image at lower power where you can see here this chronic inflammation. There's some residual acinar cells here. Here is an islet of Langerhans, but the picture is really dominated by this profound fibrosis. And here's just one more image showing this fibrosis, chronic inflammation, residual islet of Langerhans here. So this brings us to that image I mentioned before. Here we have what we see in chronic pancreatitis, where we have our ethanol and oxidative stress leading to injury. And our inflammation is going to be TGF-beta and platelet-derived growth factor, leading to collagen secretion and extracellular matrix remodeling, proliferation of our stellate cells with pancreatic fibrosis and acinar cell loss. So what are the clinical features of chronic pancreatitis? Although it is typically not acutely fatal, the long-term outlook is poor, with 50% mortality rate over 20 to 25 years. And this is probably due in part to the comorbidities. About 10% of patients will develop a pancreatic pseudocyst, and many students ask if there's an association with increased risk for pancreatic cancer, and the answer is yes and no. So in sporadic chronic pancreatitis, perhaps due to alcohol use, we can get a modest elevation in the risk of pancreatic cancer. But since we do have about 25% of cases of chronic pancreatitis are due to hereditary pancreatitis, those individuals who have hereditary pancreatitis due to PRSS1 mutations, again, this is our trypsinogen, they have a 40% lifetime risk of developing pancreatic carcinoma. So as always, here are a few questions to help you review this material. And thank you very much for your time and attention. I hope you have found this useful.